Hello, everyone. We're going to have our third session on geriatric medicine, and the topic is going to be dementia and the great pandemic of Alzheimer's disease. So I can see there are 30 attendees, 36 by now. And so as you have already seen the past two sessions, you have already been familiarized with Professor Mark. He has tried all his best to join us today as well. I'd like to say thank you. Just to tell you a little bit about Professor Mark. He's Emeritus Professor of Geriatrics and Head of Center of Global Health at the Faculty of Health Science and the University of Kyiv. And he's the former Director of Medical School for International Health, and he's currently the Associate Director of Global Health at the Medical School for International Health. And I'd like to say thank you, and let me tell you a little bit about Epidemic. I wanted to notify our attendees that we're going to prepare a session exhibition next week on September 9 and 10, which is going to be held on Ethio Post office. We have prepared many things, including, let me show you the poster. We have prepared music. We're gonna have blood donations, and we're gonna have free screening for people who want to get checked. And we're gonna have a canvas so that people can draw and they get to express their feelings through art. And I think it's gonna be really good program, and make sure to join us on September 9 if you also want to know a little bit about Epidemic and other corporate, other organizations who work with us. Make sure to check out on September 9 at the post office. And we're going to have blood donation as well. And if anyone wants to donate for Epidemic, we're going to share the link in the comment box. So to tell you about our CME, so make sure to attend the whole session so that you can get the 2 CE units we're gonna be having today. And we're gonna send Google form for anyone who is new. We would like to say we're gonna send a Google form so that you can answer the questions. If you answer 50% of it, you'll be given the certificate. And it might take 1 to 2 weeks to get your certificate, so stay tuned. And so I'll leave the floor for Professor Mark. We can start.
Great. Thank you very much. Good afternoon, good evening. I guess you have to stop sharing. And then I'll start sharing. Let's see if I can do this again. Voila. You see that? You hear that?
Yes.
You see the mouse? See the wire? Okay. Yeah. Great. Okay. So this is the third in a series of lectures that I've been privileged to give to you. It's always a pleasure to be with you. We have clear skies today, 30 degrees in Jerusalem. And wishing you all peace and things should settle down in my country and your country. So today we're going to talk about a subject that's near and dear to my heart, which is the subject of dementia, or another synonym for that is cognitive decline. Just a second, something's not, just a minute. There we go. And again, I don't have any disclosures to make on this talk. First of all, so the issue, we'll get to what dementia is in a minute. You probably don't, but it's going up. The prevalence, the number of cases is going up from 1900 to 2050. You can see it's going up in both females and males. There's a bit of a confidence interval. So you're not going to be able to avoid this. It's still relatively low compared to 20, 30 years ago, but it's going to start to rise in incidence and prevalence, or in prevalence very, very soon. So it's not something you can avoid in any country. Start with the case report. This fellow.
Sorry, Professor Mark, can you please make it on the slide share? Sorry to disturb you.
I'm sorry?
Can you make it on the slideshow?
Ah, yes, sure. Of course. I guess I can't see that. I didn't do that. Just a minute. There we go. Okay. Of course. Thank you. So here's my disclosure with the dollar sign now winging its way. Here's the global prevalence going up from 1900 to today and tomorrow. And you can see that what you have today is not what you're going to have tomorrow. So you cannot avoid this problem. No doctor can avoid this problem. Let's start with a case report. In 1981, this gentleman was age 70, was functioning well. He had a general anesthetic and had some mild personality changes afterwards and some less involved in life, less dynamic, delegating responsibility. 5 years later, it was noted that he decompensated mentally under stress. He couldn't make decisions. He had mild confusion, memory loss noted by family. By 1989, he retired at the age of 78. 89 to 92, he had continued progressive memory loss. He couldn't remember conversations. And by 1994, I don't know what took them quite so long, he was given a diagnosis of Alzheimer's disease. So I want you to think about who this person might be. Here's a hint. Does anyone remember this fellow? Put it in the chat if you would. I want to see if you know who this guy is, who this guy was. Why can't I see? I can't open the chat. Why is that?
You're saying Reagan? Yeah.
Exactly, Ronald Reagan, correct. This was the president of the United States. And if you look back, he was president at this time. So we had a demented president of the United States who ran the country reasonably well, but he had good people around him. We now have a different president of the United States who's about 80, who will be 80 years old. He's not demented quite clearly, although people claim he is. It's just a political ploy. He's not demented. But you can see that this is a disease that's quite common. It affects presidents and princes. Now, something important, I'm going to use the word dementia a lot. Dementia is a syndrome, which means it's not a particular disease. It's caused by any or all of these diseases. And today we're going to talk primarily about Alzheimer's disease, which explains the majority of dementias, but not all of them. So it's an umbrella term for a syndrome, which I'll go into more detail later. But I'll use the terms today, dementia and Alzheimer's, pretty well synonymously, although you should realize that there are some causes of dementia that aren't Alzheimer's. So where does it come from? What is it? We don't really know. Alzheimer's this is Dr. Alzheimer, 1910. This is his first case, Mrs. Auguste Deter, who was only 50 when she was diagnosed, 50. And he presented this case at a meeting of neurologists and psychiatrists in Germany in 1910 or 11. He gave a case presentation of 20 minutes. He sat down, everybody clapped, and that was it. And nobody paid much attention to his discovery. He did neuropathology on her until many years later, but that was the first case. What is it? So what's this dementia syndrome? You know, this syndrome is not a disease. It's a collection of signs and symptoms, sometimes caused by various pathologies. Well, I use, as we do in medical school, I use a mnemonic to remember the different functions that can be affected in a person with dementia. And the first is I, M-A-J-O, imago. I is intellect, the ability to understand. Memory, the ability to remember. Affect, one's emotional lability and stability. Judgment, whether you're oriented to time, place, or person, and whether you can speak your mother tongue without losing words and without becoming confused with words. There's also something which we won't talk too much about today called BPSD, that's behavioral and psychological symptoms of dementia, which are not so much this, but are aggressiveness, hypersexuality, screaming, wandering. Those are the kind of behavioral symptoms. These are the cognitive problems that a demented person suffers from. And in the end, although it might start with memory, it might start with a fallen intellect, it might start with inappropriate judgment, in the end, all of these domains are affected and the people die of the disease. So at the beginning, it could just be one of the domains, but by the end, they're all there. Okay, now, does dementia happen to everybody? Well, the answer is no. The answer is quite, they used to think in Alzheimer's day, they thought that if you lived long enough, everybody would get demented. And that was an understandable assumption in those days, but now we know that's not the case. We know that there's a whole, I think I brought this concept up in the first session with you, geroscience, which kind of claims that aging is the main pathology, and these are manifestations of aging. And here we have Alzheimer's disease. This is a debate. I don't want to get into it except for you to be aware of it. But clearly, Alzheimer's itself has its own pathology, its own symptoms, and we can recognize it when we see it. Before we get to dementia syndrome and Alzheimer's disease as the main cause, there is normal age. There is normal aging in the brain, just like there's normal aging in muscles and in eyes and in hearing and in respiratory function. You can't see my big lungs here, but there's a normal deterioration with time in all of these functions. So how do we determine whether someone's just got an old brain and is otherwise normal, or whether that person is demented? Well, let's start with the cognitive changes that happen with all aging people. Who's this? Let's put in the chat. This is someone you should recognize. Put the name in, please. Winston Churchill, right? One of my heroes. You've got it right. So this is Winston Churchill, who became Prime Minister of England in 1939 at the age of 65, and was the Prime Minister for almost 6 years during the Second World War. And he functioned extremely well, despite being an older man. So there is no change in normal age, in the normal brain that gets old but is not sick. There's no change in any of these functions. I won't read them to you. You can read. There is a decline in normal aging in what we call time tests, how long it takes to push a button, certain nonverbal skills. This is very interesting. The ability to simultaneously attend to multiple channels of information, meaning that I'm not as good as you are at walking down the street, looking at my cell phone, doing this, looking and watching out for traffic. And many of you people do this, and that's because you can do it. I recommend against it. It's dangerous, but you can do it better than me. Now, is that a sign of disease? It's just a sign that I can't do everything at once like I used to. Now, that's no change, decline. What about improvement? Some things actually improve. You could argue that some old people are wiser than some young people. Here I have one datum for you. This is a survey done in the United States last year, and they asked 3 questions. They should have said, whom do you sympathize with more, because whom is a object of with, doesn't matter. Whom do you sympathize with more, the Ukraine or Russia? And it looks like older people sympathized more with the Ukraine than younger people. Now, this is a war. It's quite clear who the bad guys are in this war. It's Russia. And I think that this shows a lack of wisdom in young Americans. Do you think Russia is deliberately targeting civilians in Ukraine? Every bit of knowledge we have says yes 100 times over. But there were some young people that said, no, it's not true. They're wrong. And many who were not sure. What's not to be sure about? Just open the paper. And do you care who wins? Looks like most people over age 65 cared very much, and they cared that the Ukraine would push back against this aggression. But again, there were a significant minority of young people that said they don't care, or they weren't sure. I think this shows, at least with respect to this particular question, that old people are wiser than young people, at least on the days between March 19th and 22nd, 2022 in the United States. It may not be the case all the time, but there is some evidence that older people are wiser. Maybe we learn from our mistakes. Maybe we aren't under as much pressure. I'll be interested to hear in the Q&A why you think that might be. But it certainly is a fact that these don't change, these get worse, and these may improve with age. Here's an interesting picture about normal aging. You can recognize, who's this? Who's this? I need to see in the chat who this gentleman is. This handsome gentleman is. Who is that? I don't see any answers. Exactly. It's me. And who's this? Who do you think that is? Guess. Who's this person here? Can't be me. Right? My son, exactly. I've got 2 sons and my older son. And you can see that we perform together. Now, why do I show you this picture? First of all, it's nice to introduce my son to you. nice looking guy. Because I found when I was practicing with him, before we had a gig together, we would practice and we would learn a new song, and we'd be practicing, and he'd say, get a bit irritated with me because I'd make a mistake or I'd have to go over the verse again. And he'd say, Dad, what's wrong with you? Why can't you learn these lyrics? And I had an epiphany. The penny dropped, the bird dropped. And I said, oh, his name is Jonesy. That's his nickname. I said, Jonesy, it's because I'm old. It takes me longer. It takes me longer to learn new songs. It takes me longer to learn new songs than it used to. But I can still do it. It just takes time. You have to be a bit patient. How patient do you think he was with me? Let's see in the Q&A what you think. How patient was he? Very, not at all. What do you think? I think the chat, guys, is just you four. I don't see the rest. How come that is? Am I seeing everybody? Oh, everyone's there? Okay. What was the question? I can't remember the question. But he wasn't patient. Yes, not very, exactly. Because young people, you're right. But I won't show him this. Young people are not as patient as old people. And he's an example. And I'm his dad. Why should he be patient? But that's just to show you that I managed, but it took me a little bit longer. You have to be patient with older people. Okay, now let's get into dementia. There's something called pre-dementia, which is termed mild cognitive impairment, or MCI. And these are patients who have subjective complaints of memory and have some objective cognitive decline, but not more than 1.5 standard deviations from what you'd expect. So it's still within the normal range, but it's lower. There isn't a clear cause. They're functionally independent people. Some of these people, but not all, will progress to dementia. MCI, mild cognitive impairment. Remember, all people who are labeled as dementia pass through the stage of MCI, but not all people with MCI develop dementia. That's a very important concept. So I want to show you, that's a simple slide. I want to show you a less simple slide that says the same thing. We have normal aging and abnormal aging. We've got normal, super normal people like Churchill, and people like me, age-consistent loss. All right, now you've got aging people, some of whom have dementia. You've got aging people, some of whom have mild cognitive impairment. You've got aging people who become demented. They have early dementia, like we saw with Ronald Reagan. In that Ronald Reagan story, early on, he had mild cognitive impairment. Later, he was demented. He had to go through this stage. But some lucky people, have benign cognitive impairment, and they never go on to dementia. They're just a bit forgetful, maybe more forgetful than the average, more forgetful than young people, but they don't go on to this. So just because you see someone with MCI, okay, with subjective complaints, a little bit of memory loss, no clear cause, they're independent. They may be passing into the early stages of dementia. They may not. So you say, I want to see you again in 6 months or a year. You may just have normal aging changes. Let's wait and see. This important concept I want in the question and answer. If it's not clear, I want you to let me know. Okay, let's continue along. Voila. Okay, epidemiology. How many people have dementia? What do you think? Let's do in the Q&A. Let's ask a little question. Oh no, in the chat, pardon me. The question is, what percentage of old people, that is people over age 65, are demented? Take 100 people over age 65 of all ages. What percentage are demented? 100%, 50%, 5%? Put in some numbers for me in the chat, please. Don't be shy. 50%, okay? 1%. That's a pretty big range. Keep going. I want to see some other numbers. Anybody, any other guesses? That's a pretty big range between 80 and 50. 30, I like 30, 30, 5 to 7, 25. Okay, we're getting lots of range. That's great. Okay, well, we don't, you have, in Ethiopia, we don't know how many people, we don't know the epidemiology of dementia because it hasn't been studied. So any of you that want to become professors and become famous, get yourself involved in epidemiological studies of dementia in Ethiopia because they haven't been done yet, and you'll get them published. Okay, so what we'll do is we'll look at the Canadian Study of Health and Aging, which was a very nice study that knocked on the doors of people in the community and tested them for dementia. And here you see prevalence of dementia, prevalence of Alzheimer's. Let's just look at the dementia numbers. Over age 65 in Canada, when this study was done, 8% of people were demented. Of all the people over age 65, if you narrowed it down to those survivors who made it to 85, a third of people were demented. But all people over age 65 was about 8%. And if you look at international studies from different countries, there have been some studies in low-income countries, but not good ones. But we have studies from China, we have studies from European countries. It looks to be like over age 65, it's about 8% around the world. Okay? So let's look. What do you think? Let's do a quick on the envelope estimate of how many people in Ethiopia are demented. But before we do, I want to show you what's going to happen in the world between today and 2050. This is the percentage of people, the rise in prevalence of dementia. So red is there's going to be a huge rise in prevalence, and blue is going to be not much rise in prevalence. So we see, let's zero in on your country. This is this is Egypt, and you know the countries under here. So you're in the very, very red zone. So we know that in Ethiopia, the prevalence of dementia is going to go up from 380 to 2,000%. It's probably about 400% in the next 50 years. And in the countries that are already old, it's not going to go up as much. That's because, well, we'll get into that in a minute. But you're going to have a huge rise in the prevalence of dementia because you have a lot of young people, and within a few years you'll have many old people. But what are I forgot the numbers yet. I will. Let's look at. This is what it's made up of. What characterizes the rise in prevalence? Here we have, you see, it's almost 4%, 400%. You're in Eastern Sub-Saharan Africa, right? So this yellow, just let me get the colors down, it's a bit hard. This yellow is change due to the effect of risk factors, which we'll get into in a minute. This blue is the change due to the population growth. So most of, this is a bit of a trick, most of the rise in prevalence will just be because there's more people in Ethiopia. And the green is change due to population aging. So your population is growing, it's aging, so you're going to have more cases, prevalence of the disease. But it doesn't matter how you look at it, you're going to have 4 times the number of demented people by 2050 than you have today in absolute terms. Okay, I hope you followed that. And in the world, the whole world, not just Ethiopia, we see, I have to move this out of the way, it's bothering me. The absolute global burden, where are demented people today? Here we are, right? This is 2020, here we are today. And you can see that the prevalence, the cases of dementia, there are more cases of dementia in the low and middle income countries there are in the high income countries, simply because there's more people in these countries. So you have to always distinguish between the percentage and the absolute number. The percentage of people who are demented in the low and middle income countries is lower because you have fewer old people. But the absolute number is higher because you have more people. Okay, I hope that I haven't confused you too much, or not at all. Okay, so Ethiopia, let's use this 8% over age 65 to estimate. Well, we know that there are approximately 5 million people over age 65 in Ethiopia. 8% of that is 400,000. So you have almost 500,000 people today in Ethiopia with dementia. Now I'm going to ask the chat, I want to know if you're surprised by that. Very surprised, not surprised at all, or somewhat surprised to hear that there are more than almost 500,000 people in Ethiopia with dementia. Anybody surprised by that? Not surprised at all, okay. Some surprised, not surprised. Some of you give me thumbs up, surprised, okay. Well, good, we'll go into why that is, but whatever the reason is, you've got nearly 500,000 demented people, and soon, very, very soon, you'll have 4 times that number. 4 times that, absolutely, okay? So, there's good news and bad news. The good news, or a pair of news, the good news is we see a rising prevalence because there's more old people, but we see, paradoxically, we see a falling incidence. Now, for those of you, just to remind you about your epidemiology, prevalence is the number of present cases. Incidence is the number of new cases. news, and news. Okay, so we see a rising prevalence because there's more old people, but we see a falling incidence. Now, incidence is new cases per 100 people. Take 100 people today, take 100 people 10 years ago, take 100 people 20 years ago. There are fewer people with dementia among the elderly today than there used to be among the same group of elderly. And we'll see why in a minute. So it turns out that there's a falling incidence, and they did a nice study in the UK. They looked at two cohorts, people over age 65 in 1989, and looked at another cohort 5 years later, all the people over age 65 in 1994, okay? 1994, 5 years earlier, 5 years later. What did they find? They found something really interesting and surprising. They found that the prevalence of dementia went up with age. So we see more dementia in very old people. Remember I said about 35% of people over age 85 have dementia, and only 8% of the total 65 plus have it. So as you get older, the incidence, the prevalence goes up. But you can see that the incidence, new cases in 1994 were fewer than in 1986. Again, we looked at a bunch of people over age 65 in 89, a new group of people in 94. This group of people had fewer new cases than this group of people. Fewer. Okay? I hope that's clear. And the same thing happened in the United States. This is the study. Here it is. It's from the New England Journal. This is a slide which you must never show in a talk. Never show such a slide. But I'm showing it to you just to show you that this is a slide. If you read the article, if you read this article, whoops, you can look at this table. But basically what it says with lots of numbers is exactly the same thing as this. New cohorts have less dementia than old cohorts. New cohorts of old people have less dementia than old cohorts of old people. Okay, so what's the cause of this Alzheimer's disease? Well, we don't know. We don't know. We know a lot about the disease. We do not know what causes it. We know what the risk factors for it are, the protective and risk factors, but we don't know what causes it yet. And if we did, maybe we could find a treatment for it. So what are the risk factors and protective factors? Well, the first risk factor, never forget, is age. These 4 lectures that you're attending so assiduously are all about aged people. And while Alzheimer's showed that the disease can happen in a younger person, the epidemiology is that it's almost always in very old people. Not always, but almost always. So the risk factors are age, like hypertension, like diabetes. There's a genetic component. So people whose mothers or fathers had Alzheimer's are more likely to get it for reasons unknown. If you've had a significant head injury, even once in your life, the chance of getting Alzheimer's goes up. Interestingly, we'll come back to this. This is really important, that the vascular risk factors, the same risk factors that cause stroke and congestive heart failure and kidney failure and ischemic heart disease, seem to not cause, but seem to bring out Alzheimer's disease. So that's a very important statement. I'll come back to it. People who are depressed have more, and hearing loss seems to be a risk factor for Alzheimer's disease as well. Now, there's also protective factors, and the most interesting is education. The more educated you are, the less likely you are to get dementia at any age. So cohorts of maybe this is explained by the fact that these people were more educated than these people. It's very possible they were, explaining why this cohort from 1994 had less dementia at every age than the cohort from 1989, because they were better educated. Who knows? But we know that education is a protective factor. We know that good nutrition, physical activity, intellectual activity, learning new lyrics. Get what I mean? Remember, I was trying to learn a new song. My wife does Sudoku, and she does word games and number games. I learn new songs, and I hope I'm protecting my brain by doing that. And having a good active social network, being part of a community, having a job, having a family around you, having friends around you, all these are protective. Okay, this is a slide. I normally don't show slides like this, but I want you later after the lecture to go back and look at this Lancet article, which you'll be able to find very easily. I can send it to if you can't find it, I can send it. It's basically the life course approach to dementia throughout life and what causes it. So we have early life. The reason I say you don't show a slide like this is because the words are very small, but I think you can see it. Early life, middle life, and late life. And it shows all the different risk factors and protective factors, which I just showed you. Okay, it shows all the same ones. And it shows where they have their effect. So here you've got hearing loss in midlife, which they think attributes 8% of dementia. And they show traumatic head injury, which they say is responsible for 3%. And they show education, which they show is responsible for, I can't see, is that 7%, and so on. And smoking and depression, etc. The bottom line is these authors from the Lancet claim that 40% of dementias are potentially modifiable via attention to these risk factors. In other words, avoiding these and encouraging these. So there is some hope, even though we don't know what causes the disease, and even though we don't have a treatment that cures it, we do know which risk factors bring it on, and we do know which protective factors protect against it. So we have what to do as doctors. And fortunately, the recommendations that we'll make for this are the same recommendations we make for diabetes, congestive heart failure, ischemic heart disease, which is to take care of the usual suspects in addition to these other ones. Okay, how do we diagnose the disease? Well, there's no blood test and there's no X-ray that will diagnose Alzheimer's. This is very important. There's no blood test and no X-ray. It is like depression, a clinical syndrome. And if you recall, clinical, you ask about intellect, memory, affect, judgment, orientation, and language. And the doctor is saying to the patient, according to this, you've been having a back problem. So it's just a clinical diagnosis. Now we do, oh, there's another cartoon. The doctor says to the wife of the patient, he's getting better. He can remember everything now except getting married to you. So there are blood tests and there are X-rays we do to look into non-causes of Alzheimer's. Remember I showed you that there are other causes of dementia other than Alzheimer. Alzheimer is not, we don't know what causes it. We don't know how to cure it. The other 20% of causes of dementia, sometimes, I'll give you an example, hypothyroidism can give you a dementia syndrome. Certain medications like benzodiazepines can mimic Alzheimer's disease. So you do a history and you do a physical and you try and rule out the 20% of diseases that aren't Alzheimer's. But if they have Alzheimer's, there's no blood test or X-ray that will diagnose it. It's clinical. Now you might have heard of the Folstein Mini Mental Status Exam. Can I just look at the chat and see if any of you have heard about it? Anybody heard about the Mini Mental Status Test? Just say yes or just put in the chat yes or no. Yes, 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 yes. No, keep going. No, yes, 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 yes. Okay, that's good. A lot of you have. Okay, that's good. That's good. Okay, so many of you have, but some of you haven't. What it is, it's a questionnaire. And I'll show you in a minute what it is. It's a questionnaire that you ask patients. You test their memory, their language, their orientation, and the maximum, which is what you guys get, is 30. A normal person has a 30, and if you've got less than 20, you've got a likelihood of dementia. You don't diagnose dementia on the basis of a mini mental status exam alone, but it does help. You have to adjust for age and socioeconomic status. So if someone's very old and if someone is poorly educated, we don't call them demented we might give them, if they're 25 or 22, we might say, you know, that's mild cognitive impairment for a person without an education, a person who's very old. Okay, do not make a diagnosis of dementia only on this, but it's a very helpful test. And here it is, and here's a bad slide again, but it just shows you, and you can look this up afterwards. You can Google Mini Mental Status by Folstein. It'll show you what it is. And what we look at is date and orientation and place, and we ask them to register 3 objects and serial 7s, blah, 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 naming things, repeating a phrase, verbal content. It's a whole bunch of domains, and each one of them is scored. And in the end, if you get a perfect score, you get 30. So look this up after the talk, for those of you who aren't familiar with it. And you can read about how to do the test, and it will help you. It'll give you some likelihood that a person has got dementia if they have a low score, and some likelihood that they don't if they have a higher score. Okay. You also have to assess the person's function, their activities of daily living and their instrumental activities of daily living. Can they use the phone? Can they understand money? Can they go shopping? Can they do the laundry? Can they cook? Things that they could do, have they lost those functions? And this is named after a friend of mine, Professor Howard Burden from McGill. We calls it the Burden-Paris test. It's more for rich countries than poor countries, but you'll get the point in a minute. He said to children who brought their parents in, who were suffering from cognitive decline, are you worried if I, the son or daughter, went to Paris for a week, would you worry about your parent? If the answer is no, they don't have dementia. If the answer is yes, they might have dementia. So it's a bit of a joke, but you'll understand if you live in Gondar and you're going to Addis for the week and you've got parents back home, would you worry about them while you're away? And if you say no, they can look after themselves quite well, they're not likely to be demented, or certainly not likely to be seriously demented. If you say, oh, I'm afraid to leave them alone at home, they might burn the place down, that's a sign, a rough clinical sign that they have dementia. I mentioned that there's no blood test that shows you have Alzheimer's, but there are blood tests that you do to rule out other problems. So if someone's severely anemic, they might not think very well. If someone's hypothyroid or even hyper, if they have electrolyte disturbance, calcium, glucose, etc., these things rule out other diseases that mimic Alzheimer's disease. Okay. Do you need to do neuroimaging? Do you need to do a CAT scan of the brain? You already know the answer because I said no X-ray will rule in Alzheimer's disease. But there are you do an X-ray. If you do a CAT scan, you don't have to do it everywhere. And in poor areas like Ethiopia, I wouldn't send someone, by plane to Addis at great expense and have them spend their year's salary on getting a CAT scan. It's not because it doesn't rule in. What it does do, it rules out 3 conditions that are very rare that can mimic Alzheimer's. Stroke is one. It's not so rare, but stroke can cause dementia. Normal pressure hydrocephalus, look it up, NPH, it's rare. And brain tumors. Some brain tumors can cause a dementia-like syndrome, and the only way to diagnose those is by neuroimaging. So if after a careful history and physical examination, you think there are localizing neurological signs or symptoms, or they have incontinence and they have a funny gait, that could be NPH, normal pressure. But these are rare diseases. So in the context of Ethiopia, in your setting, I do not recommend that everyone gets neuroimaging. In richer countries, I still think it's a mistake. I don't think you need to I don't do neuroimaging in patients that are clearly demented after I've done the blood tests and my careful physical and neurological exam. But many people do, and there are 2 schools of thought. This is the Nixon-Kennedy debates back in 1962, and there are 2 schools of thought, and I think I've told you before, there are 2 schools of thought for every medical controversy. There's mine and the wrong one. So I have my own view of this, but I should let you know, it's a minority view in rich countries that you don't need to do neuroimaging for everybody. In poor countries, you definitely should do it because it's way too expensive and too disruptive. For the 1 case in 1,000 that has a brain tumor that you miss, don't impoverish 999 people. Okay, so what's our clinical approach to the disease? First of all, those of you who've been with me for the other lectures know that I'm a big believer in prevention. So the first approach is prevention. The second is to explain to the family what's going on, because they often are perplexed. They don't know what's happened to my father, what's happened to my husband, what's happened to my father-in-law. You have to explain to them this is disease. They're not crazy. It's incurable, unfortunately, but there are ways to handle it. You treat the symptoms, the BPSD, behavioral and psychological symptoms of dementia. You treat those when they're really bad with small doses of antipsychotics, haloperidol, risperidone, and you follow up, trying to support the family during this terrible disease. And it is a terrible disease. How do we prevent it? Well, you'll not be surprised. You've seen this slide before, I think. You prevent it by the usual risk factors that we want to treat in young people, not in old people. You want to do this in young and middle age to prevent all of these diseases, cardiovascular, cancer, diabetes, chronic respiratory, and dementia. As I said to you before, oddly enough, for reasons we don't understand, the same risk factors that cause stroke and ischemic heart disease seem not to cause Alzheimer's, but bring it on earlier. So if you were going to get Alzheimer's at age 80 and you did all of this, you might be able to postpone it to your 85. And if you're a smoker and a drinker and you're obese and you don't do physical, it might start at age 75. These things seem to unmask Alzheimer's disease. It doesn't cause it. Okay, so careful attention to these these aspects will help you to prevent the disease in your patients. This is another way of looking at it, non-medical. It's being aware, sleep, activity, hyperlipidemia, glycemic food and diet, empowerment, in other words, not taking someone's responsibilities away, etc. So all of these things are preventive, and they may postpone Alzheimer's disease in people who are going to get it, and they're good on their own. So I'm not recommending anything you wouldn't do anyways. But if you do these things, you'll be able to bring the prevalence and incidence down. And as I've shown you before, there are articles. You don't have to reinvent the wheel. Look up PLOS medicine. There's a nice article on packages of care for dementia in low and middle income countries. That's extremely relevant to you people. You don't have to make it up. It's already been written, and they'll give you some guidance about how to look after. Again, it's Alzheimer's. We don't know what causes it. We know the risk factors and protective factors. There is no drug that cures it. Many people in rich countries take certain medications called anticholinesterase inhibitors. They're called donepezil. They're called rivastigmine. There's new drugs that you'll read about in the New England Journal, Aduhelm, which you have to take an injection for. None of them cures Alzheimer's. Some of them help some patients some of the time. So if you've got a rich patient that can afford a drug like donepezil, you can try it out. But if they're poor, don't waste their money on these things. Okay, what about specifically approach in low and middle income countries? First of all, as you know, 2/3 of these people live in areas with few medical services, with very low levels of awareness and low help seeking. That's your job. You're going to do this during your activities. You're going to do this during your webinars. You're going to do this during your spots on radio. It's important that people are educated as to what this is. They don't think that a spirit has gone into their mother or a witch has cursed them. Okay? We don't look for early diagnosis. We look for timely diagnosis. In other words, because it's not really preventable, it's not something you screen for like a mammogram or sugar or things of the, there's no reason to screen for something that's going to happen anyways. But you don't want to leave someone into the late stages where they don't know what's going on. Again, you optimize physical health, cognition, et cetera, and you can treat these behavioral and psychological symptoms through small doses of antipsychotics. And as I said, provide information and long-term support to caregivers. There are routine packages of care that I just showed you. It should be delivered by primary care teams. You don't have to be a neurologist or a geriatrician or a psychiatrist working in a collaborative care insofar as you can. And again, this is my sort of take-home message to you. The efficient care delivery for dementia in low and middle income countries is integrating these care with that of other chronic diseases in primary care. So you have to strengthen primary care to look after hypertension, diabetes, ischemic heart disease, and dementia within the care. We have in wealthy countries, we have dementia clinics where people like myself who are specialists in this see the difficult cases and teach residents and young doctors. So you may have read about dementia clinics, and we have them, but that shouldn't be your first investment in Ethiopia. In a poor country, I wouldn't do that. You might want to have a couple for training purposes, like 1 or 2 in the national center. That makes sense. But every hospital doesn't need a dementia unit run by geriatricians, because you don't have any geriatricians and you have very few neurologists. So try and use your resources wisely. Okay, so I think I pretty well come to what I want to present. I hope I've helped you to understand what this problem dementia is, Alzheimer's being the most common cause, how to assess it. Treatment is, as I said, symptomatic and more in the form of education than it is in actually the use of drugs. I want to remind you that if you're not interested in this problem, it doesn't matter. It's going to hit you. This is the change in prevalence, the number of cases. It's going to go it's going to be, I hate to keep showing Africa as the country where everything's happening, but it is. Africa is the place of growing population. Africa is a continent that's aging. Because it's aging, you're going to see a huge rise in prevalence of disease. You can lower the incidence by careful attention to these things. You can lower the incidence, which means that you'll have a high prevalence, but not as high as it could be. And that's your task, to lower it more, to lower it as much as you can through the general public health measures that I've recommended to you. And you can look at this map and see that some places we don't have data for China and India. It doesn't mean that they're not. Oh no, we do. They're going to go up by only 200%. Okay, only 200%. You can see that Canada is not going to go up much because it's already an older country. The United States is not going to go up much. Those countries that have gone through their demographic transition already have dementia. The numbers are going to rise, but not as much as countries where the population is going to age very rapidly, as you'll recall from my previous slides. Okay, so that's the end of this. Just to remind you, the next week, the next time I see you is the end of October, and we're going to talk, here we've talked about what we know in aging. Here we're going to talk what we don't know, and some of the research questions that I think are interesting to consider. And since you're almost all of you young doctors, if you want to make your career in aging or geriatrics, the kinds of things that will win you the Nobel Prize in Medicine, I'm going to give you some tips onto what the research questions are in next time. And I'll talk to your leadership, but I might, if we have time, I might talk about this, and I might also talk about how to publish in not necessarily articles in aging, but how to publish in the literature. We'll see if you want that, because we do have an hour and a half, and I tend to finish pretty quickly. So we'll see. But what we'll talk about is what are the main questions in geriatric medicine and gerontology, and where you're going to win the Nobel Prize, how you're going to win the Nobel Prize. So Amsa Ganalo, Toda Oba, thank you very much. And I'm going to let you turn things back to your fearless leaders and give you your quiz, and we'll go over the questions together once you've done it. So I should stop sharing, right?
Yes.
Right?
Yes, Professor. You can...
It doesn't sound good to say stop sharing. Don't you teach your children to share? We should always share, but okay, I'll stop sharing. There we go. Okay. All right. Now I'm going to stop sharing and you can share. So I hope that was clear. I'm happy to answer questions. I should answer questions after the quiz, right? That's how you want to do it?
Yes. So Dr. Miron is going to share the link on the chat box. So everyone trying to do the questions. Make sure to answer 50% of the questions. And I can see in the chat box, they're saying it's excellent presentation as always. It's really interesting and really entertaining as well. So make sure to check out the fifth question. You're supposed to answer the last question. It's a good question. So Dr. Miron, are you able to share the questions?
And I see Dr. Fitzum's comment about research. So and publishing, you'll let me know before whether you want a separate session or you want me to merge it with the next one, but we don't have to discuss that now. But I'm open to a fifth session on that if you wish, but you don't have to. Same price.
Great, thank you. I think Dr. Miron just shared the questions, so we can move on to the questions that was asked by our attendees.
Okay. But these are questions, okay, but this isn't the okay. But you want me to answer these questions now, or go over the quiz, which is the what would you prefer?
First, I think Dr. Fitzum has asked one question. We can start from here.
Yeah, what was his question? I saw it for a second, then it disappeared. Just a minute.
Yeah, it says most common question I get during clinic visit is patients asking me about supplements to help them improve brain function and prevent Alzheimer's. Is there any proven supplement that prevents dementia?
Is there any what that prevents dementia? Show me can I see the question that's easier for me to read it than to you, because I can't hear you so well. It was on the chat, I think, no? Yeah, here it is. Most common question. Patients asking about supplements. Supplements. Okay, so the question of supplements in general health. If the general answer is, if you eat a healthy, variegated, variable diet, you don't need supplements. Supplements are for people with disease. So you might need calcium if you're very old and osteoporotic. You might need vitamin D if you never go out into the sun. But in general, supplements are a waste of money. The only people that benefit from supplements are the drug companies that make them and the pharmacies that sell them. Now, someone who has a very poor diet because of poverty, because of illness, one can consider supplements, but it's generally a waste of money and waste of time. Okay, so can you scroll that down a bit? There's why the lifespan of Ethiopians is lower. Well, the lifespan of, we discussed that in the first and second lecture. That's not the subject of today, but in general, it's not the lifespan. Maximum lifespan of Ethiopians is the same everywhere. It's the life expectancy is lower. And the life expectancy is lower because people die young. You still have people make it to 120 in Ethiopia, but life expectancy is an average number made up of the number of years that people live. And if children die in childhood, they're going to lower the life expectancy. Okay, what is the role of reduced brain volume in imaging and diagnosing dementia? Okay, so that's a good question. One of the normal, if I didn't put it in my slide, but one of the normal changes in aging is the shrinking of the brain. The brain shrinks just like the muscles shrink. It shrinks. And that might explain some of those non-pathological changes in aging. I didn't say that the brain doesn't change with age. It does change. It just doesn't. We have so much reserve here that unless you have a disease, normal aging won't affect you. It's only when you have diseases that affect. So some people used to do CAT scans. It's now, there's no reason to do a CAT scan to measure brain shrinkage, because brain shrinkage is a function of age, not a function of dementia. The older you are, the smaller your brain will be. It does not mean you have dementia. Okay, what was the second question? You've slid up now. I can't, someone's typing here on the, okay, 2. 3, perhaps since infections may common having imaging help. Well, infectious diseases are not, infectious disease can cause delirium, cause encephalitis. That's a different story. But this chronic slow decline in cognition is not caused by infection, and a CAT scan won't help you with that unless you've got an acute brain illness, which is another story. That's not dementia. Okay, 4. Is oral health and Alzheimer's related? I read an article about the relation between dental health and hippocampal atrophy. Okay, so remember, relation. Correlation is not causation. Correlation is not causation. If you look at the number of cars in the world, it's gone up in the last 50 years. So has the amount of the number of Alzheimer's disease. So has the amount of cancer. The number of cars do not cause Alzheimer's disease or cancer. These are just correlations. However, there is some evidence, that chronic inflammation caused by chronic dental disease cause dementia, but it can exacerbate it, and certainly can exacerbate ischemic heart disease and things of that nature. But it doesn't matter. My answer is that you should have good dental health, whether or not it's related to Alzheimer's. So again, good dental health is important for all of us, and especially to older people, because if they've got bad dental health, they suffer. Number 1, they have pain and discomfort. Their teeth fall out, which is not a good thing. And 3, it affects their nutrition, which can therefore bring dementia on earlier. Okay, can we number 5, certain stressful situations in routine life, like the cause of, can precipitate? No. So here, that's a good question. What happens is, a lot of times an elderly couple will live together for many years, and one of them will be slowly dementing. And then the healthy spouse dies. Suddenly, it's quite obvious to everybody that the wife left behind is demented and can't function. The husband has been taking on all the functions of the couple and not hiding the dementia, but managing it. The minute the healthy person is gone, you suddenly see the other person who you didn't know was demented is demented. The other thing is, does this sudden death, let's take a terrible situation where an older woman loses her child, or loses a grandchild. That's a very stressful situation. It won't cause dementia, but it can certainly exacerbate, it can certainly cause grief, bring on depression, and as a result of that depression, make it look like the person is demented, but it doesn't cause dementia. Tau blood test for early detection. There are Taoists, and there's all kinds of biomarkers that people are looking into that will help predict Alzheimer's. And there's some interesting research. The reason I didn't bring it up here is because I would not recommend you using your scarce health dollars on these risk factor measurements. These risk factor measurements are things for specialized dementia clinics, research projects, etc. If you get a grant to look at tau and look at other things, various markers, biomarkers in elderly Ethiopians, go for it. But that's research, and that's not clinical care. Aducanumab. Okay, this is a new drug. It doesn't cure Alzheimer's disease. If the normal slope of Alzheimer's disease in this, Aducanumab makes it like that. There's still a downslope. It doesn't cure it. It's also terribly expensive. It also requires subcutaneous injection, and it has side effects. So I don't even recommend this drug in Israel, which is a rich country, or Canada. I don't recommend that the government pay for it. More so in Ethiopia. You've got other fish to fry. I wouldn't waste a single dime. I wouldn't waste a single cent on this drug in Ethiopia. You have other priorities. Do you think the absence of geriatric medicine is making such cases? Absolutely. That's a great question, and the answer is yes. Insofar as people don't understand this disease, and there aren't leaders in your field pushing research and teaching medical students and teaching registrars, et cetera, then people come to their doctors, and the doctors don't know what to advise them. They don't know to come to their doctors because they think it's just normal aging. So yes, there's a lot of reasons to increase the development of geriatric medicine in Ethiopia. One of which is the problem of dementia, but it's not the only one. Okay, can we incorporate with palliative? Yes. Anytime you want to incorporate, I'm for it. In other words, again, you don't need to have a cohort of thousands of geriatricians to look after old people. General physicians, family doctors, general doctors in Ethiopia should be able to look after Alzheimer's disease. The geriatricians are the specialists that help family doctors deal with the difficult cases and lead the research and lobby the government. So I'm all in favor of you having geriatricians, but I know there isn't one geriatrician in Ethiopia. You better not wait for geriatricians before you start to treat your demented patients, because I showed you're going to have a 400% increase in prevalence within the next 30 years. Lecanemab, that's another new drug. My answer is still, it's the same as with Aduhelm. Expensive, side effects, not recommended either in a rich country. That's my minority opinion. There are, as I said, there'll be two schools of thought, mine and the wrong one, but there's no argument about this in my mind in LMICs, because you have to prioritize and not waste your money on things that have minor benefits, if any benefits, and cost a lot of money. Okay, supplements we've dealt with. The supplements are to the drug companies and to the pharmacists. That's whose income is supplemented. Unless someone's sick, that's another story. Is there good evidence for the link between digital a lot of apps which solve or did? Yeah. Look, older persons everywhere in the world, and I'm sure in Ethiopia, most older people are not digitally literate. And digital literacy is a good idea for anybody, and it should start. You should do it in Ethiopia too. But there isn't evidence even in rich countries that these apps have any significant, and I underline the word significant, beneficial effects. Okay, higher dementia and development is proportional, or it's just, yes, you're quite right. It is because the incidence of higher dementia in the developing world in LMICs is because the prevalence is going up because you've got more old people and you've got more people. That's the reason. Per old person, you're probably not much higher. If you take 100 Ethiopians over age 65 and 100 Israelis over age 65, there'll be a slight preponderance of dementia, more cases in the Ethiopians than the Israelis, because in general, the Ethiopian elderly are not as healthy as the Israeli elderly because they live in a poor country and they've had, they haven't had access to good medical care for as many years. So insofar as you will raise the quality of your general medical care for everybody and for every age, you'll reduce the you'll reduce the incidence of this. You'll reduce the number of new cases, or it's a bit sophisticated. You may not reduce the incidence, but you'll postpone it into old age. So if I'm going to get Alzheimer's disease anyway, I'd rather get it at age 80 than at age 75, right? Just like cancer. If you're going to threaten me with prostate cancer and tell me, well, you know what, Clarfield, we can postpone it to your 85 and not when you're 75, I'll buy that. Even if I still get the disease in late age, I will have 85 years of healthy life. So we want to try and reduce the incidence, push the prevalence into the future, and reduce the number of cases we see. But again, we don't know the cause and we don't have treatment. So this is, you may finish this lecture and shrug and say, what did I waste an hour listening to Clarfield about going on about the disease for which we don't know what causes it and we don't know how to treat it. Well, I hope that the information I've given you today will help you understand the disease better, maybe get involved in research, be able to answer your patients' questions, and encourage a healthy lifestyle that we know reduces the incidence of Alzheimer's, ischemic heart disease, cancer, stroke, kidney disease, respiratory disease. So all the things that reduce those diseases also will reduce the incidence and therefore the relative prevalence of this disease. Okay, so those are the questions written. Are there any other questions that popped up that you want me to look at?
No, there aren't any questions.
That's it?
We have
okay. Let me look at the chat. Hold on one second. One of the students, let me look at this. I see these are greetings from students who, yeah, Mola, right. Greetings from friends. He's one of our exchange students from Gondar to Beersheba. Well, I'm great to hear from you. We want you to come back, and I want to come back to Gondar as soon as there's peace. As you know, I was in Mekelle not that long ago. My wife is going to be in Ethiopia in November, and I hope to come back soon. Let me just see if there's anything else in the questions, in the Q&A. Yeah, you managed to get them all in there. Okay. So I will love you and leave you unless you have any other further questions.
If we can do the questions for just 5 minutes,
oh, sure, the quiz? Sure. You want to show it to me? Show me the...
I'll be sharing it right now.
Okay.
Can you see it now?
Here we go.
Yes.
Okay, slide down a bit. Okay, dementia is inevitable concomitant of age and will happen to anyone if you live long enough. The answer is false. Lots of people die in old age without dementia. It's more common in old people, but it doesn't happen in all old people. Okay, good. Alzheimer's disease affects approximately what percentage of those over age 65? The answer is B, 8% of those over age 65. It goes up in the very old, but if you take the 65 as a group, it's only 8%. Globally, most people living with dementia in the high-income countries, no, most people live in your countries, in low-income countries, because there's more people. That's basically the reason why. The absolute number is higher. Which of the following isn't part of that's bad English, I apologize. Which of the following are not among the 4 main risk factors? Genetic factors, they are. Advanced age, they are. Lack of education, they are. Vascular risk factors, they are. Trouble peeling fruits and vegetables, no. So that's not a risk factor for, unless you already have Alzheimer's. Okay, And this is a bonus question. Who remembers song lyrics better, myself or my son? Well, it says, oh, Professor Mark remembers song lyrics better than his son. The answer is true. It's actually false, but I want to try and manage. Okay. So good to see you all.
Yeah, we would like to say thank you. You can see from the emojis that the session was really.
Yes, I can see them floating up. People cry. Why are people crying? I don't understand. They should be smiling. Yeah.
It's a laughter emoji, yeah.
They're crying from laughter, I see.
We'd like to say really thank you for preparing this slide for us. We'll definitely send it through their email, or we'll be sharing it through the Telegram group. And we'd like to say really thank you. And our attendees, make sure to join us on October 29 for the sessions. Well, we don't know, so we have learned about dementia and basics of geriatrics and the like. So we'll be discussing in one session on what we don't know on October 29. Make sure to tune in again. And I would like to say again, thank you for your excellent presentation, Professor Mark.
My pleasure.
Yes, we'll see you after a month.
Ciao, ciao.
Bye.
Thank you so much. It was excellent.
Dr. Pinson, nice to hear from you. All the best to you all. Thank you for inviting me.
Thank you.
Bye-bye.